All right, hi everyone, it's Katie Wiskar back from UBCI and POCUS. This is another pathology video. So the point of these videos is to show you some examples of what pathology can look like, as often when we're learning these ultrasound techniques, we are scanning normals, just so you can get an idea of what kinds of things you might see in your patients when you're scanning them on the wards. So today we're looking at some lung clips and specifically looking at A lines and B lines. So this first clip, this is a lung ultrasound. We're using the curvilinear probe on the abdominal preset. We've got our tissue harmonics and multi-beam ideally turned off. We can see two rib shadows here. And then in the interspace between, we see a bright pleural line. And then we see what looks like B lines coming down from it. But specifically here, we also see what we call a subpleural consolidation. So that roundish anechoic space or dark space right deep to the pleura. So that's a small consolidation. We can see that in a number of pathologies, really classic for things like infective endocarditis with septic emboli, peripheral pulmonary infarcts in PE, but also just kind of standard pneumonias and infectious causes. And then we see a lot of what looks like B lines, but are actually called ring down artifacts, just coming down deep from that. Okay, another lung ultrasound clip here. We see a couple rib spaces with ribs here and here. What we want to draw our attention to here, so we see these vertical artifacts coming down, so B lines. And remember, in the context of B lines, we can sometimes look to the pleural line for clues as to whether these B lines are cardiogenic in nature or from an infectious or inflammatory etiology. And there's a whole video on this on the website, so I encourage you to watch that. But what we want to pay attention to here is the fact that the pleura looks quite irregular. It's not really crisp and bright and smooth. And there's a reduction in pleural sliding compared to what we would normally see. So this picture would be more consistent with these B lines being from an inflammatory or infectious pathology. So this here is another lung ultrasound clip. This one is taken with a phased array probe on the abdominal preset, which you can also do. We don't see the rib shadows themselves as well in this clip, but we clearly see a bright pleural line at the top of our screen. We see bright vertical artifacts coming down from the pleural line. They move with respiration. They go all the way to the bottom of our screen. So these are B lines. And we can see that they're fairly homogeneous across the interspace. The pleura also looks fairly smooth accompanying these B lines. So we would probably say that these B lines, these vertical artifacts, are more likely to be associated with cardiogenic pulmonary edema. And again, we would look for other clues like their distribution, whether they're symmetrical on both sides, whether they're more prevalent at the bases, whether there's associated things like pleural effusions. But just looking at these B lines themselves, they are more in keeping with pulmonary edema. This is just some A lines. So rib shadow, bright pleural line. And then we see equidistant down from the pleural line at regular intervals, we see A lines. Now here we can see 3, maybe 4. Really, you only need to see 1 A line for it to count. And in some patients, especially patients with more soft tissue in between your probe and the pleura, you may only see 1 A line, but it's always nice when we see multiple. And the move to try to bring these out again is going to be fanning, right? To make sure that your ultrasound beam is nicely perpendicular to your pleura. Here we have some more B lines, so these vertical artifacts. We've reduced our depth a little bit here in this clip, and what that allows us to do is often get a better sense of what's going on at the level of the pleura, right? Because again, in the context of vertical artifacts or B lines, we can pay attention to the pleura to let us know whether these might be from pulmonary edema versus something infectious inflammatory like pneumonia or ILD, ARDS, that kind of thing. And here we can see that this pleura looks quite ragged and irregular. And really important when we're making this assessment, you need to try to make the pleura look as smooth as you can. So you need to employ that fanning and try to get the pleura to be as smooth and crisp as you can, because we can always make it look a little bit ragged and irregular if we're just not perpendicular to pleura with our beam. So if you do your best fanning and the pleura still looks ragged and irregular, that's again supportive of this kind of infectious inflammatory B line picture. Here we have some more B lines, less dense than previous, I would say, despite what this caption says. And here in contrast, the pleura looks really regular and smooth. And we actually still see some A lines kind of in between the B lines. One of the The kind of axioms of B-lines used to be that they should erase all A-lines, and that was true with older ultrasound machines and kind of older settings. The way ultrasound machines have evolved now are such that you may still see some A-lines kind of in between the B-lines, but we can see here that there are certainly B-lines. They go all the way down our screen, they move with respiration, and the pleura that they arise from is quite smooth. So this would be supportive of a degree of cardiogenic pulmonary edema in this interspace. All right, this clip is a little more challenging to see, but what we're trying to point out is a lung point. So a lung point is the only pathognomonic finding for pneumothorax. Other things like reduced pleural sliding can suggest it, but there's a differential for other things that can give you reduced pleural sliding that is not exclusive to pneumothorax. However, if you see a lung point, then you know that you've identified a pneumothorax, and what you're identifying is the barrier between the location where the two layers of pleura, the visceral and the parietal pleura, are sliding and opposed as normal, and the area where there's air in between those two. And what that looks like is you can see here on screen left, there's some pleura that's sliding kind of halfway across that interspace, and the rest of the pleura is staying still and there's no sliding there. So we call that a lung point, often better seen with a linear probe rather than the curvilinear. This is just another nice normal example, rib shadow, interspace with a nice bright pleural line, and then we see one A-line, maybe a second one under there, but this is enough. I would be happy that this looks like nicely aerated lung with A-lines throughout. And we have good depth here. Remember, we don't want too much depth when we're scanning the lung parenchyma, somewhere between 8 and 11 to 13 centimeters, depending on how much soft tissue there is usually plenty. Here we see a bit of consolidation, so we'll get more into these consolidations in the next video, but something to point out is that we see some vertical artifacts here on screen left, and some of these are kind of coming down from that shredded hyperechoic pleural border along the edge of the consolidation, and that's called a shred sign. So a shred sign is when we have some of the lung that's consolidated, so the more peripheral part, but not the whole thing. So we see some of that consolidation, and then we see this shredded border, this bright border, where the consolidated lung interfaces with the aerated lung. And then we see these bright vertical artifacts coming down from that. And those are technically not B-lines, although they have a very similar appearance. This is an interesting clip. So we have two kind of rib spaces that we're seeing here. The one on screen right actually looks like A-lines, right? We see a pleural line and then we see an A-line. And then the one more kind of in the middle of our screen, we see some really dense vertical artifacts coming down from this and coming down from quite an irregular pleura. You notice that there's kind of a dip in the pleura there. So this would be a very characteristic lung pattern seen in something like ARDS or pneumonia, where there's skipped areas and spared areas of the B-lines and the pathology is unevenly distributed throughout the lungs. Here's some more nice examples of B-lines. So this time in contrast, the pleura is quite smooth. We also note that the B-lines are arranged quite symmetrically throughout the interspace. So instead of all the B-lines arising from one little point on the pleura, they're evenly spaced throughout that interspace. And that again is in keeping with cardiogenic pulmonary edema as the likely etiology of our B-lines. Here's one more time, just some A-lines. This is on a slightly different ultrasound machine. But we can see rib space, and then bright pleural line with some A-lines equidistant beneath it. And sometimes you can get some other horizontal artifacts in there that can be a bit confusing. So a good reminder is to check the distance between the skin and the pleural line, and you should expect to see your A-line equidistant from that. So if you're seeing other horizontal lines at other distances, those are not true A-lines. Here again, some B-lines arising from what appears to be quite an irregular pleura. You can notice how there seem to be little divots in the pleura and little kind of focal spots that the B-lines are coming down from. This is done on a lung preset with a phased array probe, which is, again, good to show you how these things appear on different machines. And I'd encourage you to play around with some of the different presets. We tend to find the curvilinear probe easiest, especially for novices, because you become better oriented by seeing the two ribs and then your interspace. And we will typically, unless we've designed the lung preset ourselves, use the abdominal preset, ideally with THI and multi-beam turned off if we're scanning the anterior lung, the parenchyma. Again, have a look at the dedicated lung videos on the website for more details on all of this. Here's some more B-lines. So we see a couple interspaces here. We see a rib shadow. And then especially here, kind of slightly to screen left, we see bright pleura, which looks fairly smooth with some B-lines arising down from it. Here's another example of a lung point. This one's much more clear. It's taken with a linear probe, so a high frequency probe. So we can see we've got rib. Rib is always going to be higher up, more superficial than pleura. So we have rib, pleura. And then just coming in on screen right there, you can see this little kind of knife of pleura that shows normal sliding, and the rest of the pleura in our interspace does not demonstrate any sliding. So this is pathognomonic for a pneumothorax. This one is more challenging to see. And again, this is some of the reason why we often encourage scanning with a curvilinear probe, just because it, as I said, gives you better visualization of the ribs and then the interspace, and also does give you better definition of the pleura. But here we have pleura line right at the top of our screen that looks fairly irregular with some vertical artifacts coming down from this. So I would say this is in keeping with kind of infectious inflammatory B-lines in this space. But again, not quite as easy to see, and I'd probably want to have a look at this pleura either with a curvilinear probe or with a linear probe to give me some more details here. This one is good to show you just so you're aware. So when you're scanning the left side, especially kind of the L2, sometimes L3 region, and especially in women, if there's breast tissue in the way, you will often run into heart, and you will see heart on your screen like we see here on screen right. And sometimes that's just inevitable. You can do your best to work around it, but sometimes heart will just get in the way. What we see in the rib space next to heart here is another little subpleural consolidation. So that kind of roundish or triangular, anechoic, dark little space right abutting the pleura with vertical artifacts coming down from that look like B-lines. So again, this is suggestive of something infectious inflammatory. ARDS, septic emboli, pulmonary infarct, a little peripheral pneumonia, something like that. This is another example to show you that we can sometimes see mixed A and B lines, especially with our modern ultrasound machines. And I would still describe this as having B lines present. The fact that we can see an A line here doesn't negate the fact that there are B lines. When we're talking about B lines, it's useful to quantify the degree of B lines. And some research studies will actually have you counting the B lines, and that's totally impractical for real life. So I tend to use a descriptor and say, sparse B lines or few B lines versus, really dense B lines or, plentiful B lines, or even coalescing B lines, which is when we see there's so many B lines that it just looks like a big triangle of white that's moving back and forth. So I would say this is, relatively sparse B lines. Actually, it's a decent burden. I would say this is like moderate burden of B lines with some A lines kind of visible in the background here. Here is a nice example of our coalescing B lines. So you can see there's so many B lines that it actually looks just like a big kind of wedge of white that's moving back and forth with respiration. If you're not sure what you're seeing, if maybe you're not sure if this is organ or mass or something going on here, sometimes playing with your gain and turning down your gain a bit will let you see that movement with respiration. And if we look at the pleura there, we can see that these B lines are kind of moving back and forth with respiration. So in the setting of, for example, pulmonary edema, this would be suggestive of a very high burden of lung water, very severe pulmonary edema. Okay, that's all. Again, please check out the lung videos on the website for more details on how to scan and some details on interstitial syndromes specifically. Thanks.